Can you see the case number
Yeah,
4?
case number 4, just dive right in.
Good. So this is a 77-year-old male who has history of hyperlipidemia and prior smoker. Presented initially because of a positive stress dyspnea exertion. So actually positive stress echo, which had hypokinesis both in infralateral as well as anterior wall. A cath had shown that he had essentially 2 vessel disease, had RCA PCI on 4-5, and today here is for a PCI of the LAD. So if you see what we have in this case, EF, which is normal. So he had an anterior takeoff of the RCA.
Yes.
Which needed AL catheter engagement, and our PCI site looks good. And today here is for PCI of this, I would say moderately calcified proximal LAD. At the level of the lesion, I think it's mild calcium, but definitely 1-1-1 bifurcation of the LAD diagonal.
Okay, and how is the LV function again? I'm sorry, I missed it.
Normal.
I know that
Normal.
unknown.
Yeah.
Okay, but you have it. You've done it by angiogram, no?
No, it's normal.
It's
EF is
normal.
Oh, normal. Sorry,
60%.
normal.
Yeah.
Okay, wonderful. Okay, great.
So you can see here.
First
this
of
is
all,
the
thank
EF.
you for your great cases. We saw that the final result of that last case came out gorgeous. So we saw it and we appreciate that. So here's another case, another bifurcation lesion. This one doesn't look calcific at the site, but there's a lot of calcium on the way there, on the highway. We have this great panel. Why don't we start? Anyone who wants to tell us what the approach would be? Maybe Dr. Chandra?
We actually did the OCT. They can show you the OCT, show the OCT live.
Oh, good.
Just the run.
Go ahead.
So what we found that at the level of the D1, it's just more than 2 quadrants of calcium. This is at the level of the D1. You can see that calcium. Show the calcium. Just show the arrow. Yeah, that's where the calcium is. And also it's significant disease there. And further down, there is some disease in the LAD, but no calcium there. But like you mentioned, in the proximal LAD, if you go there, is significant calcium in the proximal part of the LAD.
So it's interesting. You now are using OCT. We see the octade above with the aid that you've put together so beautifully for those people who are unfamiliar with OCT. This is a beautiful app. But tell us, when do you choose to go IVUS OCT, this imaging? The last 3 cases you used IVUS. Here now you're doing OCT. What's your rationale on choosing which imaging technology?
Yeah, very interesting question. I think you got to make sure the lesion. See, the first case, we already had TB2 flow, was very tight disease in the LAD. There's no way we wanted to go all the way down. Now, we were going to do the IVUS of the left main. So when you are doing ostial or distal left main, you have to be careful. OCT, you need a lot of dye clearance, which we'll not see in that particular region. That's why we selected IVUS. So if you are doing LAD, circumflex, RCA, as long as your vessel is not larger than 4.0 and your lesion is not more than 95%, where you know there's no dye clearance, you can use OCT. And all these things, which cases you can use OCT, IVUS, this is all mentioned in our Octade app. And more important, I think what is important is recognizing the lesion, calcium versus lipid. This is the key where we have nice pictures of everything that is shown in that app, so we can make a decision. I think from here, what I would say, since we have 2 quadrants of calcium, we would say it's moderate, between moderate to severe. Remember, the classification is same, 180-degree arc. So we are just at that border of 180-degree arc of calcium. And should we do, if you go with our calcific app, it will tell you at 180-degree arc calcium, or angiographically, if you're not sure, you did do your imaging. We did imaging, and I think based on the imaging, we definitely decide we are going to do atherectomy, not atherectomy, and the question now will come same, raised earlier by the panel, that which atherectomy device. So here, you could go both, and we have selected that we are going to do orbital atherectomy.
Oh, very interesting.
Flora.
Okay, so go ahead. Somebody on the panel wanted to say something?
What about shockwave in this case?
Yeah, so before we even
also,
get there on which one, because I think we talked a lot about in the last panels which one we would choose. But Dr. O'Neill, are you agreeing in this approach? I mean, if you hadn't imaged, you might have not gone to atherectomy, or would you have anyway, because you see there's a lot of calcium getting to the lesion?
I think a lot of it is depending on how familiar and how comfortable you are with the procedure. I mean, this is one, I tell the fellows to try to find reasons to do it because you don't want to do a rotablator on a 90-year-old with
Can't hear.
horribly calcified vessels. So I think this is a relatively straightforward, I think it'd be very safe to do it, and there's a lot of calcium in the proximal part of the vessel, so I'm fine with that.
Yeah, and Aleide, you're talking about which atherectomy device. Would you choose a
Ablator, I don't think would be my first choice on it.
we can't hear you well. Can you talk straight in?
Yeah, rotablator would not be my first choice in this case, honestly. I don't think it's really 360-degree calcium. You can go or more conservative with non-compliant balloon, and then if you see the neck, then you move forward, or maybe this is a case for shockwave.
Okay, but I think the OCT did show a lot of calcium. No, Dr. Kinney, please tell us, did the OCT
Go back, show the OCT. Just
showed
show
360 degrees, right?
No, it's not 360 degree, 180. So,
Oh,
you know, the
180, I see,
cutoff,
okay.
even in your European guidelines, 180 degrees is the cutoff for going for atherectomy, and that is where we are. You pull the wire
Okay.
back.
Any
So-
other? Dr. Chandra, Dr. Takwan?
Yeah, I see this lesion by angio in the proximal calcification. What is the luminal diameter area? That's number one. Number two, I think this case can be done by radial approach. Doesn't seem to be lead to the femoral.
Okay, so we'll go to that. I think that's a very good, there are a lot of radialists, and we do perform a lot of radial interventions in our hospital. In fact, Dr. Kinney and Dr. Sharma have turned into that, their attention into that. But here, Dr. Kinney, so one, what is the, are you planning to treat that calcific area that you just discussed, that you're thinking about using atherectomy? Are you going to then treat it? Obviously you will, right?
Yeah,
And
I
what was
think-
the luminal diameter there?
So if you can see what the OCT is showing, that's at the level of the exactly 3.2 millimeter squared area. That is at the level of the diag. This is what they wanted, yeah.
It definitely needs to be treated, is
Yeah.
what you're saying. And what about, why didn't you go radial?
That's an interesting question, and here there is a significant diagonal, which you would say you're about 2.5 millimeter diag, which is branching. And if we are going to do that we selected that we would either go for mini crush or technique, and that's why we went with the 7 French groin. But I agree, if anybody wants to do radial and get more radiation exposure, do DK crush and be here for a longer time, you can do that route too.
Okay.
Because
Okay.
every month I get the email that the radiation is beyond what is acceptable for a human. So I have to be very
Okay.
choosy.
Dr.
But
Dr.
you had a
Colombo?
fellow, right? You had a fellow there.
I came in later. Can you? I
Yeah,
didn't
so this
see
is
the
a case of
angiogram.
a-
I didn't see the angiogram. Can you just run
Yeah,
the angiogram?
it's a case of as you see, it's a LAD diagonal lesion with some calcification on the way there, and you see she's doing the atherectomy. Tell us what you're doing exactly. Walk us
So
through
this
that.
is a diamond back orbital atherectomy. It's the same thing with the slow pecking motion backward and forward. So one big difference between the rotational atherectomy versus orbital atherectomy, you see the rotational atherectomy, your diamond chips are only in the conical. You see that rotabar, which is conical. So if you see only in the, the proximal 50% has the diamond chips. So it will only do atherectomy when you're moving forward. But in the orbital, what it does, it orbits around the vessel, so it does atherectomy moving forward as well as coming backwards. But whatever it is, you are not going to do more than 20 seconds of atherectomy, so when it beeps, you stop.
Okay, so I heard the beeping and you stopped. And are you more worried about things, or you feel very confident using this? Because many, many operators in the U.S. now are turning their attention to this technology as opposed to rotational atherectomy. What advice do you have for them? Dr. Kinney.
Okay, so the reason I think everybody wanted so we're coming out here, right? So one new thing that they have a glide assist, what they have started, new glide assist. For that, I just wanted to show you. So there are 2 speeds here. So
You
this
see
is
that on the
80
right panel, everybody, is what
Yeah.
they're showing. Okay, go ahead.
80,000 RPM and 120. So I'm just going to press here for 3 seconds, and then it's going to become glide assist. Good.
Is
And
that,
then-
is that the
yes.
second generation Viper wire or is still the first one?
I think this is the Viper 2nd generation, right, Dr. Kinney?
Yes. Now, going back to your original question is what would I advise people going to OA versus RA? Was that your question? Right?
Yes, exactly.
Yeah, in this kind of case, you could select both, or I would go with what Adelaide just mentioned at 180-degree calcium arc. If you want to just do a balloon, see how it expand, and if it was okay, there was nothing wrong, just to do high-pressure balloon. And if not, you can use cutting balloon and do that. Now, the question about shock wave, we do not, it's only under trial, shock wave. For shock wave, in a vessel that we showed, which was the case 1, case 3, those are the cases where you would not try shock wave, only because you want to make sure the device will reach the lesion. So the LED, the first LED where we did, where you had a TIMI2 flow, the bulky shock wave may not reach there. So you ideally need ROTA or OA to go to reach to that area.
Hold on.
Yeah, that's really good point. That's really good point.
So
Any other, Dr. Kwan?
We have
other
3 atherectomy.
Is the shockwave approved in the United States or it's not?
No,
So
no.
that's the investigation use.
It's investigator, yeah.
Yeah,
Then,
Roxana.
Yes, please.
Yeah, so we have a surgeon among us, so one of the questions he had
Yeah,
was...
I was going there. Don't
No, no.
worry, I'm going there. But,
No,
but did you
what-
have anything to say
Yes.
about the intervention?
Yes. One of the questions he had was, what happens to these particles? So the difference between the ROTA versus the CSI, the particle size, right? It's believed that the CSI causes smaller particle size, maybe 2 microns versus the 5. And also the other thing we talked about was the heat generation may be less with this than with the ROTA. So this may be more easily handled by people who don't do as many cases as here, and that may be an advantage in this case.
Yeah, I mean, I think that's one of the reasons why they've been able to
5 or 3,
do
yeah.
okay with this. We
The
have
other reason I got your question, Roxana, you wanted
Yeah.
to know why people would go for OA, because the
Yeah.
current newer generation, we all trained in a generation where only rotational atherectomy was there. Like I mentioned in my first case, our left leg still keeps working. You understand?
Yeah.
We are so used to rota with a pedal, we are not used to. So I think not just interventionist was not just hand-eye coordination. You also need a leg coordination when it comes to rota. So the newer generation was finding it harder. So when OA came and it was only with the hands, everybody wanted to do OA. So, but now with the Rota Pro, where you don't have the pedal, everything is with the hands, exactly like this particular device. I think you just have to, be that you just become proficient in one or both, and you just have to know when to use which one. And you have our apps to help you with that.
Yeah, no,
12 and
absolutely. So as you know, we have Dr. Puskas on the panel. He performs amazing, excellent robotic surgery here at Mount Sinai in the healthcare system, and is an excellent surgeon. Dr. Puskas, you evaluated. When you get a case like this, you're thinking to yourself, I can put a Lima to the LAD and then we're done with it, or are you saying, well, Dr. Kinney, she's doing an amazing job. I don't need to do that. I'll keep that for the next time. How would you approach something like this?
Well, I think it's important to
3:12.
recognize the concept that can does not equal should. And I think it's also important, we're going to be talking later this morning rather, about the relative merits of PCI versus CABG. I think in general we do too much CABG in old patients and too much PCI in young patients. And I think that we do both groups a disservice when we do that. This patient is 77, relatively old, has a long, relatively complex calcified proximal LED stenosis. It's going to require extensive atherectomy and multiple stents, and I expect Dr. Kinney will get her usual beautiful early result.
Yep.
The question is, what will it look like 1 year, 3 years, 5 years, or more from now? compared to a robotic mammary to the LAD, which is more invasive than an atherectomy, although certainly less invasive than a conventional cabbage.
So, Dr. Colombo, how do you respond to that?
Enough here, done.
I think he's perfectly right. I think on the long term, a well-done mammary is superior. I think you have to evaluate the length of the lesion, the age of the patient, etc., etc. But maybe if you really do a very good job maximizing the lumen gain, you can get close. But I think you have to tell the patient that when you do this kind of procedure, the mortality will be the same, but he has to expect to come back maybe 3 or 4 years along the line.
So we have pre-dilated with a high-pressure balloon. We went up to 18. It has expanded well. Now, what would the panel do for this LAD with the diagonal right at the level of the lesion?
Yeah, I saw that you already protecting the diagonal. We heard a lot early on that many people want to go provisional first, always. It's a good question. Can you just show us that lesion again? Just remind us of the size of that diagonal after. Yeah,
it's a
there we go.
2.5, and after I dilated the LAD, now you see it is almost 90%, the diag.
Yeah.
It was about 70% before. With the whatever plaque shift right now, it's become 90%.
And we saw in the last case that the same thing happened in the OM. You weren't in that case.
Yes.
But Dr. Sharma just did a small dilatation there, and there was post-stenting, it looked good. But I think a lot of people here on the panel in the previous session were going for the no-touch technique, leaving this alone, going provisionally. But I don't know how everyone is thinking now. Dr. Chandra, how would you approach this bifurcation?
I feel this diagonal is pretty big, subtending more than 10% of the myocardium, and I think protecting it was a good idea, but I feel it will require a stent because it's quite a large diagonal. Now it is pinched after the pre-dilatation of LAD. So I think we should go with two-stent strategy.
Dr. Botello?
I think this is a wonderful case to discuss the generalizability of trials. And you cannot generalize this particular patient. When you visit bifurcation lesions, you visit global studies, population studies of bifurcation. But they are different regarding the angulation, the type of the lesion, calcification. So this particular patient is not contemplated in any trial. The data we have for him is just personalized data that comes from the physician experience. And from my perspective, I would also stent this branch because of all of these variables that are not contemplated and not measured in a significant way from the clinical trials.
Okay, so you would go with a two-stent. I mean, this is small. I think that side branch, even though it's covering and it's branching, it's small in diameter, 2.5 at best, I think. And you're putting 2.530 here, bifurcation. I just hate all that metal in that bifurcation and in that angulation. LAD, how would you proceed? And then we'll go to Dr. O'Neill and then to Dr. Colombo.
I would have started with the provisional approach, not predilating the diagonal and stenting the main branch, then recrossing to all the provisional. Now, since she dilated the osteum, I think there is a small dissection. So, for me now, is a two-stent approach.
I mean, I think Dr. Kinney all along wanted to do a two-stent approach. Is that right, Dr. Kinney, or not?
Original angio showed 70% lesion, and I think after we ballooned, it got worse. That is why we wired it. If I was planning provisional, I would not even wire the vessel. I am a person of no-touch technique, that if you think you're not going to do it, don't go near that. But now, since we decided that, it was 70% before, became 90. After we did a cutting balloon, you definitely see a dissection, so it will be a two-stent approach. So,
and is that all in your Bifurcate app?
Yeah, they are showing it
Yeah.
side by side, bifurcate
Yep.
what are the
We're seeing
steps.
it up there.
So we are going to do a two-stent technique, and then we'll show you this later on, because right now I think you have to go on to room 3 because Dr. Sharma is
Okay,
asking for you
great.
guys.
Let's go to Dr. Shah.
We are still not able to get anything down in this vessel.
Wow.
So
So
we are
this is
struggling here.
why rotational atherectomy and orbital atherectomy or whatever it is was needed, but maybe orbital atherectomy didn't do the job.
Okay.
So now you'll dilate with a
28.
cutting
No,
balloon, no?
we have done everything.
What cutting balloon did you use?
We used a 3.5.
Wow.
Now get me a smaller stent, or otherwise we go to Synergy.
What pressure did you go with the
3528.
cutting balloon?
What pressure did you go to cutting balloon, Dr.
With
Kinney?
the new Flextome, we went 16.
16, that's okay. I know you like
And
to go
then
to
we
25.
went with high
Dr.
pressure, 3.5, high pressure, 20 atmospheres.
Would you go any higher, Dr. Colombo?
I think
you've
you
done-
can go at 20. 20 is usually the maximum. You have to take into mind that his balloon is semi-compliant, so you have to be careful not to oversize. Because
Yeah,
when you go
especially
to
in this
20,
calcific lesion, I'd
when
be
you go
nervous.
to 20, it becomes 375.
Okay.
Maybe 370.
So what's happening now, Dr. Kinney?
No, I'm trying a shorter stent.
Shorter stent, looks like you have 2 wires there.
I have 2 wires in the
Are
LED,
the
shorter
wires
stent,
not-
still
not-
nothing is going.
The wire is not reacting with each other? You don't think it's that diagonal?
No. I think it may go now. Deep breath. See, the only thing is a guide liner, 7 French, but then same thing, you'll not be able to put 2 stents through the guide liner.
Yeah. It's rough.
Are you sure that the wires aren't twisted
Well,
on each
that's
other?
what I
That's what
said.
think.
She
Maybe-
does
Not,
think
I've
that-
rewired
no.
it.
Maybe considering that she's planning to stand the diagonal, she can put an anchoring balloon in the diagonal.
Did you hear that, Dr. Kinney? Anchoring balloon in the diagonal?
Yeah, okay, we'll do that.
Maybe you do that?
Get us a 2.512. 2.512.
Good. Any other
Balloon.
tricks anybody else have, other than, obviously, she already talked about the mother-daughter.
Just for the audience, I think that twisting the wires when you're doing diagonal, if the second wire, if the fellow or whatever is doing 360s rather than going back and forth, there's a good chance you're going to twist the wires. And the way you can tell is that nothing will track. So then when Dr. Kinney puts the balloon, if the balloon easily tracks, then there's no trouble. But if the balloon has trouble tracking, then I would just pull that wire out
And rewire.
Yeah.
Yeah.
That's
I
another.
think she already rewired that.
She already did, yeah.
I have rewired it a
Maybe
few times now.
wiggle wire in the LED. Maybe there's some white bias. You put a wiggle wire.
Wiggle wire? I've not ever seen Dr. Kinney use wiggle wire. Do you use wiggle wire, Dr. Kinney, sometimes?
We don't have it in our inventory.
You can make it.
I knew that you don't use it. I know a lot of people
Truly
talk
speaking,
about
I
You can
would
make
go
it
with the
yourself.
guideline
Look,
and
look
the
how
other.
nice that
You
balloon
get a
went,
grand
Doctor.
slam, just make a band yourself.
The balloon went very
Yeah, that's
nicely.
perfect. Yeah, that's
So let's anchor it
Full
there.
circle,
That's
yes.
a nice, this is a great thing, about these things, okay? What size is this? It's a 1.5?
It's a 2.5. It's
2.
anchoring the thing, and now
Really? It looks
let
so
me go with
small.
the 28 stent.
Okay, let's do the stent
3
now.
or 28. No, this is not the stent. This is the diagonal stent.
Give us the stent for the LED.
Yeah, you want to do this?
The right one. What size stent you going for, 3.0?
We had 3.038. That was the plan. 38 is not even making a turn, so we went to 3.028.
Okay.
Then if we need, we may have to put a stent distally later.
Okay.
Our plan was that we were going to do mini crush. We had the stent in the diag, but no, right now we are struggling to get anything down the LED.
Okay.
So let's see now. Have the guide
I
liner
mean,
ready?
it's not like, look at that.
Oh,
Beautiful. Good.
Done.
Dr. Colombo, excellent.
Okay.
Good advice.
applause to Dr. Colombo.
Yeah.
It's okay. No, I did not invent the anchoring balloon.
No,
No,
we,
no.
we know.
No, but it's wonderful because Dr. Kinney, she respects you so much. She never listens to anybody, so it's good. She has her own way.
Don't say it loudly. That I don't listen to anybody.
No, but it was a good advice. She knows when there's good advice coming. She knows. She took it right away, and I think it worked. You saw that. It's beautiful.
That's well done.
Excellent. So now you are
So I'll
going to...
try to see if the stent will go into the diag and we will finish the case. Yeah.
Yeah, now I think you will. Maybe. Let's see. That's perfect. And then we already got a little sneak peek into case number 7. So we're excited about that. No, are we going there?
No, not
You will be going there, but shortly I have to go there.
No, don't go there yet. Please go back to Dr. Kinney. Yeah.
Maybe later, but right.
Anu, still need the second wire on the LED?
No, I will take it out. I want this to go in. That's a run through. Okay, good.
Oh,
okay.
Beautiful. Now you could
Now
still
the
do
run
your
through. So
mini
both are
crush.
fielders. So that's another thing that you want. The fielder is the one where the stent is. The run through is other wire. I'm pulling that back out.
Beautiful.
That's a diag. And then what we are going to do is a mini crush technique. Some dye.
I have a feeling you can pull back on your LED stent a little.
No, I will. I agree with that. Yes. I think we are good with the
diag looks
Go.
good.
Some dye now.
That's good.
Okay, good. Okay, go up with the diag.
Up with the diag.
So you see again another mini crush here.
They are showing you the technique steps down.
We
Go up
see
again.
it. We see all of it in your
Yes.
aid, up right
Good.
above. And then are you
Down.
planning to do OCT at the end?
We could always do it.
Okay.
So now I'm going to take the balloon, then give some puff before I take out the wire. Good, looking good. I'm going to pull the LED back a little bit, ideally, right? And go up with the LED.
Yeah.
Some dye,
Little wire.
some dye, yeah.
That's great.
Go. Yeah. So after this, essentially, we are going to recross and kiss.
Yeah, that's
And then
beautiful.
we'll do the OCT at the end.
Can we go back to
Down.
Dr. Sharma first and then?